relationships which you always keep on wondering, what is this, you keep on guessing, you never understand the exact relationship between these two persons or people or conditions. So I think diabetes and cancer, diabetes and pancreatitis, keep on guessing with each research that what is affecting what, and then the science progresses. So I think the first, he is going to talk about diabetes and cancer and the oncopathy. So Dr. Anuj Maheshwari, for you.
Thank you, Shreya, for the nice introduction. And it is the first time my interaction with the our audience of the Pune city, although I have been here many times speaking for the first time. And thanks to our lighting committee, Dr. Nagalu, Nita Deshpande, who have given me this opportunity to interact with you. So in next 20 minutes, we shall be discussing about a few aspects of the diabetic oncopathy, and we shall be trying to explore the association between diabetes and cancer. It has been a long time, much debated talk. Okay. It is a long time debate about the cancer association with diabetes, or many a times people say that treatment of the diabetes is many of the time associated with the cancer. कैसे करना है चेंज? So, to explore the link between cancer and diabetes, we all know that insulin is a growth factor for a number of epithelial tumors in cell cancer system. Hyperinsulinemia produces a secondary increase in the availability of insulin growth factor, which is another known tumor growth factor. And its increase in amount is more of associated with reduction in IGF binding protein 1 level. Once the IGF binding protein is reduced, it is dissociated from that and is more available for its activities which are not so good. These changes in the insulin IGF-1 axis might be expected to favor the survival and progression of the early malignant foci. Cancer cells may thus overexpress not only the insulin and IGF-1 receptors, but also IRA, which is again kind of the insulin receptors, and hybrid receptors, which are formed by the recombination of their constituent protein. Not working. Yes. So we know that insulin and IGF-1 receptors are tetrameric members of the receptors, tyrosine kinase family, and metabolic consequences of the receptor stimulations are mediated by the phosphorylation of the IRS proteins and activation of the phosphatidyl inositol 3 kinase AKT or protein kinase B pathway. Activation of this pathway promotes the normal familiar metabolic effects of the insulin. But there is another action of this pathway is also there. There is another action of this insulin and IGF-1 receptors are there, which is the growth promoting consequences. Growth promoting consequences of these receptors are more mediated by the RAS mitogen activation protein kinase, which promotes cell growth, and 159 differentiation by regulation of the gene expression. Is there any time on okay. So this is the picture in which we can see the action of the insulin. This is the normal action of the insulin, where you can say that insulin is coming up of its usual consequences of the lipid synthesis, glycogen synthesis, and glycotranslocation. At the same time, the IGF-1 is coming up with the overgrowth consequences or growth promoting consequences in the form of the transcription and translation promotion. This insulin and IGF receptor interaction brings up these growth promotion consequences, which are also known as the microgenic consequences, and it brings in the form of the cell proliferation and anti-apoptosis. Apart from the usual metabolic consequences, which are of the glucose lowering, which is coming up by the purely insulin action. But this insulin action is associated with the IGF-1 receptor action. These consequences also start taking Usually, normal course insulin is having a very high affinity because of what these consequences are not so prominently seen, because IGF-1 receptors are having a very low affinity. But in the situation of the normal insulinemia, once the insulin level is within the normal limit, these mitogenic effects remain at the peak. They are not so much prominent, but the metabolic effects are quite prominently active. But in the situation of the hyperinsulinemia, the things get reversed. Mitogenic effects becomes more prominent and metabolic effects comes on the back seat. And because of that, type 2 diabetics becomes more leading towards the cancer association or mitogenic effects. Mitogenic effects of the insulin have been seen in number of ways, like many cancer cells have been found to be increased insulin receptor content. These insulin receptors are the two varieties, one is the A and B, isoform A and B. In malignant cells, the A isoform, which is the IRA expression, is predominant and its activation elicits more mitogenic than metabolic effects. By binding to these overexpressed A receptors, insulin may favor cancer progression and facilitate the growth of tumor. Finally, insulin mitogenic activity might be enhanced at the cellular level by post-receptor molecular mechanism. This is the picture in which the insulin receptor expression has been seen in the normal and cancer tissue. We can see that it is much more into the cancer tissue as compared to the normal tissues, and highest insulin receptor expression has been seen in the breast cancer, followed by the colon cancer and then the lung cancer. As far as the prostate cancer is concerned, this is the only cancer of which the risk decreases with the progression of the disease diabetes. When we do the meta-analysis of the relative risk of the various kinds of the cancers in different parts of the body, in diabetic patient, we see that it is not the pancreatic cancer which is highest in number or highest in risk. It is the liver cancer which have been found to be the highest with the relative risk, followed by the endometrial cancer, then pancreatic cancer, and you can see kidney cancer following that. As far as the type 1 diabetes and cancer is concerned, we have not seen the breast, pancreatic and colorectal kidney cancer more predominantly occurring in type 1 diabetes, but they have got a different set of the cancers, like the relative risk for the stomach cancer, followed by the endometrial cancer and cervical cancer have been found to be very high. A recent meta-analysis have found that relative risk for the pancreatic cancer is doubled in type 1 diabetic patient and young onset diabetes. There has been a study in the Sweden among the type 1 diabetic patient in which 29,187 patients have been screened for the cancer probability, and it has been seen that this study observed 355 incident cases of the cancer, which corresponded to a 20% increase in overall cancer incidence among type 1 diabetic patients. An unexpected finding in this study has been seen that the risk of the stomach cancer among type 1 diabetic patients increased with follow-up time. The finding may be related to the high prevalence of the Helicobacter pylori among patients with type 1 diabetes or the high incidence of pernicious anemia. If we pull up the long-term all-cause mortality in cancer patients with or without pre-existing diabetes in selected cancer sites, we can reach to a conclusion that association of the diabetes and site-specific mortality risk reached statistical significance only for cancers of the endometrium, breast and colorectal. Now come over to the association of obesity with the cancer. American Cancer Society reports that every year in the United States there are approximately 1.5 million new cancer cases and 550,000 cancer deaths are occurring. NHRES third reported in 2003 and 2004 surveys that 32% of the US population was obese, whereas 2.9% of men and 6.9% of women had a BMI more than 40. Worldwide, the International Obesity Task Force estimates that 1.1 million people are overweight, having the BMI between 25 to 30, and 312 million are obese. The relative risk of the developing type 2 diabetes by BMI category have been found to be increasing with the increase of the BMI. This has been seen in men and women both together. The risk of the cancer risk is increasing with the increasing in BMI in both the genders. We have seen the influence of BMI and cancer risk for men. We could see that highest occurrence of the esophageal adenocarcinoma, while the lowest was the esophageal squamous cell carcinoma, followed by the esophageal adenocarcinoma predominantly high in the men, those who were quite obese. As far as the women, those who were obese, we could see that influence of BMI reflected in the form of the highest incidence of the endometrium followed by the gallbladder, esophageal adenocarcinoma, renal and leukemia. Bariatric surgery has been found to be reducing the cancer risk almost in all the studies which have been done across the world. A recent Veteran Affairs case control study of over 250,000 patients with diabetes for more than 3 years has reported that diabetes is associated with a 3-fold greater odds of the developing pancreatic cancer and a 2-fold increased risk of the developing extrahepatic biliary cancer. Hepatocellular carcinoma has been associated with diabetes. However, it is unclear what role diabetes has in the development of hepatocellular cancer in those with other risk factors such as chronic pancreatitis. For breast cancer, diabetes contributes approximately 20% greater risk over those without diabetes. The strongest link is with estrogen receptor positive breast cancer. Diabetes seems to have no effect on the development of the premenopausal breast cancer. Studies of the endometrial cancers with diabetes have not had the consistent findings seen in the obesity study. However, one prospective cohort study of the US individuals reported that diabetes alone led to a 2-fold greater risk of endometrial cancer, whereas in combination with obesity, the risk increased to 6 times than of the normal weight population. There appears to be an inverse association with diabetes and prostate cancer, as we have seen in the non-obese diabetic individuals too. Is there any connection of development of the cancer with the insulin level? Because hyperinsulinemia and insulin resistance are associated with obesity and are involved in the pathophysiology of the type 2 diabetes, the epidemiological studies have measured the insulin and C-peptide levels to evaluate their association with cancer development. In a cohort study, we could see that C-peptide level, even in those patients who were not having the diabetes at baseline, were significantly higher in men who subsequently developed colorectal cancer compared with control subjects. Other studies have also shown that breast cancer and endometrial cancer demonstrates a strong correlation between fasting insulin level and cancer. Both studies reported that the association was strongest in those women not on hormone replacement therapy. Insulin and IDF signaling has got a strong connection in development of the cancer. So they have got the roles beyond those commonly recognized as medically relevant. What are those commonly recognized as medically relevant, like energy, metabolism and growth? They are usually expected to occur with this combination, but much more than that, that insulin and insulin-like growth factors are well known to cause, as well as they have got considerable evidence that these are producing the signal transduction network that regulate important roles in neoplasia. Do we reduce the risk of getting cancer by using treatment, specific kinds of the treatment? Do we have enough evidences that survivor effects can be better with the use of the metformin or insulin? There are some studies. Of course, they are not 100% making sure that this thing will give you 100% recovery from the cancer risk, but it is seen in few studies that survivor effect of metformin for the development of the cancer, where the cancer outcome have been reduced in the users of the metformin as compared to the sulfonamide. This has also been seen with the users of the insulin as compared to the non-insulin therapy, but up to the much lesser extent than the user of the metformin. And in the comparative studies in which the insulin has been seen, we have not, the researchers have not used the analogs. ADA and American Cancer Society cancer statement says the diabetes is associated with an increased risk of some cancers like liver, pancreas, endometrium, colon, rectum, breast and bladder. Diabetes is associated with a reduced risk of the prostate cancer. The association between diabetes and some cancers may be due in part to shared risk factors between the two diseases such as aging, obesity, diet and physical inactivity. Possible mechanism for a direct link between diabetes and cancer includes hyperinsulinemia, hyperglycemia and inflammation. Healthy diet, physical activity, and weight management reduce the risk and improve outcome of the type 2 diabetes and some form of the cancer and should be promoted for all. Patients with diabetes should be strongly encouraged by their healthcare professionals to undergo appropriate cancer screening as recommended for all people of their age and sex. The evidence for specific drugs affecting cancer risk is limited. Observed association may have been confounded by indications for specific drug effects on other cancer risk factors such as body weight, hyperinsulinemia, and the complex progressive nature of hyperglycemia and pharmacotherapy in type 2 diabetes. Further research is needed to clarify these issues and evaluate the possible association of insulin and other diabetes medication with the risk of cancer. Cancer risk should not be a major factor when choosing between available diabetes therapies for the average patient. For selected patients with a very high risk of the cancer occurrence or for recurrence of the specific cancer type, these issues may require more careful consideration and many research questions still persist and which are needed to be answered. What the ACE and American Cancer Society consensus statement on diabetes and cancer. Role of hyperglycemia in cancer development is less clear but cannot be ruled out. Currently, there is an insufficient evidence that anti-hyperglycemic medications may be definitely associated with an increased cancer risk. In patients who have an elevated